Welcome everyone, and thank you for joining today's Children's Hospital Colorado Genetics ECHO-Lite education session. Right now, everyone's microphones are muted, but your cameras are on, so we can definitely see all of you as you're connecting. At the end of the presentation, we will unmute microphones for feedback and questions from our audience. Should you have a question, please raise your hand, and I, the host, will unmute your microphone and call on you by the name you entered when joining the conference. Please allow me to now introduce our speakers for today's session. Dr. Janet Thomas, Associate Professor, Pediatrics with Clinical Genetics and Metabolism. Erica Wright, Senior Instructor, Pediatrics with Clinical Genetics and Metabolism. And Dr. Stefan Mokrahajski, Pediatric Medicine, Kaiser Permanente, Colorado. Thank you all again for joining us today. Let's begin.
Good afternoon, everyone, and welcome to our first Genetics ECHO-Lite session. I think we'll be learning as much as hopefully you will be learning. As we said, this is kind of a combination that I'm one of the genetics docs here at Children's Hospital. Erica's one of our genetic counselors, and Stefan is a community pediatrician who has worked a lot with children and has been roped into helping Mountain States Regional Genetworks. And this is a program that's sponsored by Mountain States Regional Genetics Network. You'll hear that term or that referred to as MSRGN probably throughout at least the beginning of this presentation. We first have to kind of, First have to kind of begin with disclosures. Myself, Dr. Thomas, I receive salary support through MSRGN as the co-project director. And MSRGN itself is sponsored by the Health Resources and Services Administration, or HRSA, which is, of course, part of the U.S. Department of Health and Human Services. So we have a grant to do work. It's a year-to-year grant, but a kind of a 3-year project. Ms. Wright and Dr. Mokrahajski do not have any disclosures that I'm aware of. So we want to begin today in that we have 3 main objectives for today. I first want to introduce the Mountain States Regional Genetics Network, kind of describe their mission, their objectives, and what has kind of brought us to this point of doing this ECHO-Lite program. We're then going to discuss some common misconceptions regarding genetics. And then finally, we are largely going to ask your feedback on future genetic ECHO-Lite education sessions or perhaps specific ECHO sessions. And so our main goal today is the third objective there, and that we love your feedback on what you guys want to know about from a genetic standpoint. So first, a little introduction to Mountain States Regional Genetics Network. Our mission is to ensure that individuals with genetic disorders and their families have access to quality care and appropriate genetic expertise and information through facilitating a professional networks of genetic clinics, key primary care practices, consumer advocates, and state health departments. So we try to involve kind of everybody that may touch children and those with genetic disorders or developmental disabilities, and involve those in the work of Mountain States. We are one of 7 regional genetic networks sponsored by HRSA. As you can see on the map, we're one of probably the biggest one, but the country is essentially divided up into these 7 regional networks. And for those of you that have been around for a while, these were previously called the regional collaboratives, and only recently in the newer grant cycle have we changed to the term networks. So here's the Mountain States region. It is an 8-state region with a combined area of over 1 million square miles. So we probably do have clearly the largest region in the country for the regional networks. And of course, from the Canadian border to the Mexico border, we cover all the mountain states. We have a population of over 49 million people within our region. Interestingly, we have 491 counties, of which 199 of those counties, or 40% of those, meet the frontier designation. And by that we mean less than 7 persons per square mile. And that's important because we, of course, are targeting underserved populations and trying to get services to underserved populations. And as you all know, our region is a lot of square miles and not as many providers. We have 5 states within our region that have a larger concentration of Hispanic and Latino populations than is typical of the other U.S. states. And we are home to a higher percentage of American Indians than the U.S. as a whole as well. We have more than 700,000 births per year, of which 3 to 5% of those babies may be affected by a genetic or congenital condition. So to accomplish our mission, we have organized and we support a network of state teams to identify and address genetic service needs in each of our 8 states. I think we recognized early on that each of our states are unique, and each of our states have unique approaches and unique difficulties that need to be addressed by those individuals that know their states the best. So we have put together state teams. This project today and this presentation is part of the quote-unquote Colorado state team, if you will, with the hope of expanding that more regionally if it's successful. We promote broad membership, and we encourage strong communication among our network members. And our network members are all on relatively equal footing. So we have healthcare professionals, including genetic specialists, hematologists. We have primary care providers, including pediatricians, family practice, nurse practitioners. We have public health professionals, those that work in the newborn screening labs, for example. And as well, we have consumer advocates and support organizations with patients and families. And again, everyone's kind of on equal footing with equal say within the organization. We share resources and solutions across the region and with other networks. And we have developed some nice collaborative projects that we hope, if successful in one area of our states, might be able to kind of expand to the further regions. And we also do some QI projects. So some examples of that are our current underserved patient population project, our UP project, which we have targeted 4 locations within the region, including Durango, Grand Junction, Tuba City, Arizona, and San Antonio, Texas, as targeted locations to investigate both via primary care physicians as well as work with the geneticists and consumers in those regions what might be most useful in addressing the genetic service needs in those communities. We do quite a bit with telegenetics, including trying to implement telegenetics, help with training for telegenetics, as well as quality improvement projects regarding outcomes of telegenetics. Currently, we're working on a developmental delay algorithm with primary care physicians and geneticists with the hope that we could distribute that algorithm to primary care practices, that they may be able to begin the evaluation of a child for developmental delay, for example, while waiting on the wait list to see genetics, because we all know our wait lists are very long. And we've done a mapping project of the region looking at genetic providers and where clinics are for the region as well, and I'll show you an example in the next slide. We collect and analyze a lot of regional data on genetic service delivery, and we interact with the regional networks across the country as well as the National Coordinating Center, and have frequent contact with HRSA itself for these goals. So this is just an example of our mapping project. I have to say, I personally just really like these maps, so I wanted to have a chance to show them. But this is an example of genetic services served here by Children's. So most of our states are served mostly by one primary genetic center. So here at Children's Hospital, you can see that our primary clinics are starred, so that'd be here in Denver. We have outreach clinics across the state, and then we also have outreach and telemedicine clinics now largely up in Montana. But you can see from the blue that those are the zip codes of patients seen by genetics here at Children's Hospital. And similarly, this is the same type of map for the region. This is a little outdated yet because we now have the Arizona data, but it shows where the patients are being served, in what locations based on zip code. So to accomplish our mission on the new grant cycle, we have 4 primary program priorities and objectives. The first is to link medically underserved populations to genetic services. And in that regards, this is a little different than our previous years as collaboratives, in that what HRSA really wants to see is really patients getting to care. We have identified the underserved population in our areas as largely the Hispanic population, the American Indian population, and the rural population. And then we need to implement quality improvement activities that increase genetic services to these populations. And we're largely supposed to implement the access to genetic services with a big push via telehealth and telemedicine. And this is a little bit different in that there's not been a huge push for clinical genetics to see patients via telehealth or telemedicine, but HRSA would really love to see this. And certainly in a region like ours, telehealth and telemedicine makes sense given the frontier counties that we have and the large rural populations that we have. And then we are tasked with distributing resources to providers, both primary care providers as well as genetic providers, to public health professionals, and to families with genetic conditions. And really, I think the challenge for the Mountain States is that we need to develop a service infrastructure throughout our region that facilitates access to services for the underserved populations and create this as a sustainable solution for our states. And this is, of course, where the genetic light echoes come in, is the resources to providers and to other individuals with genetic conditions. So as we talk about distributing resources to providers and public health officials and consumers, we have developed a new interactive Mountain States website over the last year and a half. And that website does house most of the educational materials that we have developed, both educational materials for providers as well as those for families. Any tools and other links to resources are on that website. And we've also linked the kind of quote-unquote find a clinic, a link to kind of finding a clinic if you have a family, say, moving from Colorado to Texas, or those sorts of things, or seeing where the most close telehealth clinic is. So there's a variety of resources on the website, and I would encourage everyone to kind of take a look at the website. We are hoping that we've made it more interactive and more kind of friendly for both providers as well as families. We've also charged our state teams this last year to really link resources for families to the website as well. And by this, I mean resources that the families can utilize, like faces to faces or family to family, the family voices links, the links to the public health department, to public health nursing, those sorts of things. And I personally, as a clinician, I know we have not done a great job of doing that for our families, mostly because we didn't know where those resources were located. So our state-based teams have tried hard to pull those resources together for families and put that link and that information on our website. I will note that another way that we are going to hopefully educate providers and families is an annual genetics summit. Our first annual one is coming up in October. This is going to be in San Antonio, and we hope that it brings together a broad representation of stakeholders, and we have been able to, or I should say we're working on getting CME, CNE credits for providers. In addition, we have worked hard to promote the use of a medical home portal. That's a portal that was developed in Utah, as a lot of information on that medical home portal for primary care physicians, including information on genetics as well as other topics. One of our other goals is to, of course, develop a Project ECHO presentation on common reasons for genetic evaluations. We work closely with the NCC, the National Coordinating Center, and the National Genetics Education and Family Resource Center to develop new educational materials and promote consumer engagement, or to link to educational materials that are out there. I don't think anybody wants to reinvent the wheel, so to speak, so there's a lot of information available for families and providers, and if we can link those to a more common source. Again, that was our goal for the website. As I mentioned, we're working on evaluation algorithms. We've started with developmental delay, but I think we will kind of likely survey what primary care providers would like to be able to start evaluations in their offices. And we've worked on a social media campaign as well to increase culturally competent knowledge of genetics. And so for today, again, this Project ECHO is the first in hopefully a series of ECHO presentations that might evolve as a way to give primary care physicians what you guys want to know about genetics. But first, we're going to start with debunking some myths about genetics.
Dr. Thomas. And so one of the ways to get our discussion started, we thought we would just review some common misconceptions that we've heard over the years from providers and from families regarding genetics. And so sometimes we get asked, why should we care about genetics? Why is a genetic diagnosis important? And things we sometimes hear is that these disorders are rare and untreatable, that a genetic testing is so expensive and unaffordable, and that the yield can be quite low and rarely gives a diagnosis for that individual. Some families might feel that labeling a child with a diagnosis is wrong. We also know that sometimes family history and pedigrees are thought to not be helpful and are thought to be quite time-consuming in a primary care practice. While newborn screening is a great tool, we sometimes also hear that folks think it's the only way that there might be a diagnosis for an inborn error of metabolism. But really what we hear a lot and what we feel a lot from providers is that it's just way too complicated. And so as we talk about some of those myths and debunking those misconceptions, genetic disorders are quite common. And here's a list of some of the more common ones that we see. For instance, individuals that carry a BRCA1 or 2 mutation for hereditary breast and ovarian cancer is now thought to be 1 in 400 individuals. In an individual with an Ashkenazi Jewish ancestry, that is actually a 1 in 40 prevalence. Sex chromosome disorders such as Turner and Klinefelter occurs in 1 in 500 individuals. Noonan syndrome could be as frequent as 1 in 1,000 individuals. Neurofibromatosis, 1 in 3,000, and cystic fibrosis is also 1 in 3,000. 22q deletion syndrome is 1 in 3 to 6,000. Inborn errors, just those diagnosed in newborn screening, is 1 in 4,000. Fragile X is 1 in 4,000 as well. And the more common muscular dystrophies, Duchenne and Becker, are 1 in 7,200 individuals. Another fact is that there are emerging treatments for many of genetic disorders. And with these treatments, we know that timely diagnosis is often a key in outcome. We have our long-standing therapies for inborn errors in metabolism, such as diet intervention, vitamin supplementation, medications, and sometimes even transplant. In recent years, we've seen the development of enzyme replacement therapies for a number of our inborn error metabolisms as well, such as MPS disorders, Fabry, Gaucher, Pompe, and CL2. Just recently, within the last few weeks, we've had an approval of a new medication or a new enzyme substitution therapy for PKU. We also are starting to utilize chemotherapeutic agents for disorders such as neurofibromatosis and tuberous sclerosis, progeria, and Proteus syndrome. Additionally, there are emerging therapies that are really relying on an improved understanding of the genetics behind these syndromes. Such things as exon skipping, stop codon read-through, gene repair, and gene therapy are being utilized. An example is in spinal muscular atrophy. We know that in spinal muscular atrophy, SMA, that it's a result of mutations in the SMN1 gene. However, the phenotype of individuals with SMA is actually based on how much protein is being made by a very similar gene, almost a nearly identical gene, SMN2. Typically in SMN2, there is a substitution in this gene that results in exon 7 being skipped. And basically that results in a non-functioning protein being produced. With newer treatments, we now recognize that if we are able to produce what is now known as an antisense oligonucleotide that will bind to that SMN2 gene and actually result in exon 7 being included in that final protein product, thus drastically changing the outcome of these patients. While it's not a cure, it's really showing us that with an improved understanding of these genetic syndromes and diseases, we can have better targeted treatment. Another example of this is in Duchenne muscular dystrophy, as well as we're continuing to seeing progress being made in gene therapies and clinical trials for things like OTC deficiency. Also, SMA has a number of promising gene therapies happening, GSD1A and hemoglobinopathies. Another common misconception has been that our yield is quite low, resulting in many families going through a diagnostic odyssey and not finding that answer they were hoping for. However, we know that new technology and an improved understanding of these genetic syndromes has resulted in an improved yield. The yield of the genetic testing really is dependent on our case selection. We know that for some things, such as structural heart diseases, we're not as smart as we would hope to be at this point, and therefore we have a lower yield. But for neurological diseases, we've seen a much higher yield with the ability to run large genetic testing panels. When we take in specific cohorts, such as those with developmental delay, we're seeing an improved yield as possibly high as 40% in those individuals with developmental delay. And we know based on older studies, as well as newer studies, that when there is that genetic diagnosis, in about 60% of those patients, that will alter the management of their care. We've also seen remarkable success in the reducing costs of genetic testing. So new technology, as well as competition among genetic testing laboratories, has significantly lowered the cost. Chromosomal microarrays now can be obtained for about $1,000, or thinking about just doing a single gene analysis, what previously had been a few $1,000s, we're now seeing at about $500 per gene. There's been amazing results also seen in genetic testing panels utilizing next generation sequencing. Now a large panel of genes can be analyzed for as low as $1,000. We've been working with genetic testing companies that when they are aware that a family will be paying out of pocket, they've started to offer their testing as low as $250 for a large genetic testing panel. Whole exome sequencing, which used to be over $10,000, is now about $2,000. So when you take into account that the yield of this information is improving, these testing mechanisms really are more favorable with things such as, when compared to things such as brain MRIs, EEGs, and echocardiograms. We know that a diagnosis can be useful in identifying resources and guide the management of these patients, obviously one of the main goals of our Mountain States group. The diagnosis can assist in obtaining the necessary services, as well as providing guidance. This includes not only the treatment and therapies for that patient, but also sometimes assist in insurance and legal resources. Maybe helps those families obtain things such as home health resources or nursing support. Provides the family with genetic counseling and planning for future pregnancies. Also could help with co-management of the patients. We recognize that the medical home is a critical partner with us in genetics. And the American Academy of Pediatrics has a number of health supervision guidelines for some of our more common genetic disorders, such as neurofibromatosis, Williams syndrome, Fragile X-Marfan, and Prader-Willi. Pedigrees are still helpful and thankfully not as time-consuming as one might think. In a study that was done a few years ago in the primary care setting, the average duration of a family history being obtained by a primary care provider was less than 3 minutes. Also, there are a number of online resources that can assist primary care providers in collecting these family histories. Families can complete these family histories at home and even print off a copy to bring in with them to their provider. Some providers have started to obtain these family histories in the waiting room using apps and iPads. And truth be told, we recognize that in the pediatric setting, most primary care providers are in fact collecting family histories. In a survey that was done by the AAP last year, it highlighted that 97% of the pediatricians do collect family histories, and more than half of them were utilizing some type of standardized disease checklist. And these pediatricians reported that within the last year they had identified at least 75% of them had identified a patient that was at risk for a genetic disorder. We often talk to providers that newborn screening is only just a tool in diagnosing patients. Many states now have over 30 different metabolic disorders are on their panel, but even with the improved and expanded utilization of newborn screening, false negatives can still occur. For some of the inborn errors of metabolism, just biochemically speaking, there are disorders that are difficult to identify every single newborn with them without having too many false positives. Those are things such as glutaric acidemia, methylmalonic acidemia, and our fatty acid oxidation disorders. There's also many more metabolic disorders that are not on the newborn screening panel, for which there are some metabolic disorders that there are treatment that exists that we know will improve outcome, and timeliness diagnosis is still key. And while it's a very useful tool, newborn screening is really only a small piece of the puzzle. What we're always telling providers as well is please don't rely on that normal newborn screening result to rule out all inborn errors in metabolism. But most importantly, never wait on those newborn screening results if a child is ill. There are local resources available for assisting primary care providers with genetics. One of the easiest things is contacting us here at Children's Hospital, where you could speak to a geneticist or a genetic counselor, receive some guidelines regarding next steps for getting that patient in. Knowing that our wait list is long, often we can guide providers into possibly obtaining some first-line testing prior to that genetic appointment. Also, it allows us to triage those patients so that if it does seem that there is an immediate concern, that patient can often be sooner rather than later. Also, we know that local public health departments can be great resources for families within their community. They can link families to their community-centered boards for evaluation, case management, and initiation of early interventions. Many local public health nurses can conduct a needs assessment to determine whether or not there are other needs that the family is unable to get, such as getting food through the WIC program or possibly public health nursing. Public health departments have always been essential in coordinating care for our patients and with getting to see us with travel, respite care, and even just letting the families know about local resources such as camps and such for their children. And lastly, as Dr. Thomas mentioned, our Mountain States website is something that we've been working over the last few months to really beef up and be a place that providers and consumers can go to identify those resources in their community. One last thing to note is part of that AAP survey that was done and published last year, there were some barriers that were identified by providers as far as what to do next regarding genetic testing and evaluation. And what the providers had reported was that there was a lack of training on their behalf regarding genetic interpretation, that there was lack of care management guidelines, there was lack of training in identifying genetic risks and choosing the appropriate tests. There was inadequate time within their own practice to really have time to sit with the families and talk about these genetic test results. But many providers also expressed that they were unsure of how insurance would work and whether or not this family would have to foot a large bill based on if they had ordered genetic testing. I'll turn it over to you.
Thank you, Erica. I think my job is to lead us into a discussion of what your needs and wants are. I have a kind of a three-part approach to genetics. And the first is that I consider geneticists to be excellent physical diagnosticians. So if I have a patient who comes into the practice new and happens to be tall and thin and having some lax joints, I want to be able to know right then and there what I need to do to decide whether or not Marfan syndrome would be a significant consideration and whether or not I should make a referral. Secondly, I consider geneticists to be excellent communicators. So in my practice, I've had some issues with parents trying to decide when, where, and how they would actually discuss with their child a genetic diagnosis. So one of the common or more common ones is families who have a prenatal diagnosis of something like Klinefelter syndrome, XXY, and they often do not discuss that with the child until the child is starting to get on into, late school age or even early adolescence. And so then in that case, I have a little time to do some background work on, that diagnosis. I might reach out to the Extraordinary Kids Clinic at Children's that deals with, sex chromosome abnormalities. So then I can have some time to prepare and learn how to communicate my thoughts and assistance to the family. And then thirdly, I consider geneticists to be kind of super scientists. And the things that are coming out of genetics right now are just so amazing and so interesting. Things like, for instance, the CRISPR technology that now allows us to splice genes and to really get into changing the genome is scientifically very, very fascinating. So some of the other things that we were thinking about working on to develop a series where clinicians and others who are interested in genetic issues could join us for these discussions are things about, dysmorphology. What do you do when you have a child who has some unusual appearance? Things that are diagnosed, as I mentioned, prenatally, things that turn up on the newborn screen, and then pretty much other than trauma, everything is genetics these days. So you have certain genetic diseases related to neurology, pulmonology, GI, psychology, and the list goes on. So we could answer questions in that regard if you had an interest. There might be interest in cancer genetics. I know that there are, various familial cancer syndromes that you might have experience with in your practice. We're learning a lot more about how to do pharmacogenetic testing to know exactly what drugs are going to be most successful for treatment of certain diseases. And then the list goes on: mitochondrial disease, adult onset genetic related diseases, and trying to, again, find out exactly what treatments might be most helpful for individual patients in precision medicine. You also might be more interested in, learning the exact testing techniques that are now being used in genetic medicine. So chromosomal microarray, and often primary care clinicians can start some of these testing procedures once you get an idea what would be the most appropriate one. There are a lot of questions about testing children for adult onset disorders. If you're able to do surveillance during childhood, obviously that would be much more important. But sometimes, kids, as they reach adolescence, they want to know if they have some familial disease, whether or not they're affected. And then the cost of doing these testings. I know everybody is under a lot of financial stress these days getting things approved. That would be something that we could discuss further, as well as direct-to-consumer advertising. A lot of programs out there that are offering genetic testing. You just spit in a tube and send it in, and you get information back. Well, how do we help people interpret that information? So lots of new, as Erica mentioned, lots of new therapies are available. We would like to know whether or not we should address that issue in our future presentations. Again, the Mountain States Regional Genetics Network is trying to organize resources for families. There are many, many organizations that are providing services. We would like to be able to provide that through the website or through practice information.